Good morning, everybody. Thank you for joining us here on World COPD Day for this patient seminar. My name is Chris Lamb. I am the president and CEO of the BC Lung Foundation. And yes, like I mentioned earlier, it is World COPD Day. Today, we're going to talk about the importance of keeping our lungs healthy and what are those tips and tricks that are going to keep it that way and going to keep us healthy as we move forward. Before I go further, I of course want to acknowledge that we are on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nation. Particularly important to think about the land and the environment that we're on, particularly given we're thinking about all the parts of our province that were affected by the storm yet last night. Hopefully, a lot of you who are watching this have power and are able to either watch this live as we do this or online later. And of course, this will be available on our website at bclung.ca pretty much after this is done. With us today, we have some fantastic guests that are going to guide you through that experience right here for World COPD Day. We're going to be guided by our friends over at Popular Pulmonary, Jenna and Tina. They are two of the most dedicated health professionals I've ever met when it comes to helping people breathe. So you are in good hands today with Jenna and Tina. You're going to hear from Dr. Don Sin. For me personally, one of the most world-class minds when it comes to COPD and your lungs. He's going to go through a talk with you. And we're going to have some other guests as well. You will have time for questions and answers. Feel free to drop those into those little fancy buttons that you'll find at the bottom of the screen. But without further ado, I'm going to hand this over to Jenna and Tina.
Hello, and welcome everyone. And he continues to guide us in this journey with the research that he does into COPD. And he's here with us today to share some pearls, some things to keep top of mind as you live through this journey. So thank you so much, Dr. Sin, for being with us today. And I'll hand off to you.
Okay, well, thank you so much. And hopefully I can share my screen. There you go. Can people see my screen? If not, let me know.
We're
Otherwise, I'll just assume that you can. Um, it's a great day every day, but particularly today, as you know, this is World COPD Day. We not only discuss the disease, but also make the disease aware in the public sphere that it's not only diagnosable, but it's also treatable, and hopefully in the near future it will be curable. So without further ado, I thought I spend the next 20, 25 minutes discussing some of the recent advancements in COPD, particularly as it relates to therapeutics. I work at St. Paul's Hospital in downtown Vancouver, and I've been there for 21 years. So this is the scientific definition of COPD. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms, and it's related to abnormalities in the airways, which we call bronchitis or bronchiolitis if it's involving the small airways, or the parenchyma, and that's called emphysema if it's involved. And clinically, it manifests as airflow, and I've shown you a picture of a spirometer here. In 2022, the journal Lancet commissioned a report on COPD, and I was fortunate to be part of that, to go beyond just airflow obstruction and open up the curtains and see what's behind it. What causes COPD? And I think for most public, the number one answer will be cigarette smoke, but there will be much more, as you can see. So there are five major classes of what we call idiotypes, drivers of COPD, and they span from in utero to childhood and into adulthood and senescence. Type 1 is called genetic, and approximately 0.5% of COPD cases in North America are genetically related. Type 2 is early life events, including asthma and oops, prematurity, bronchopulmonary dysplasia, and so on. And then type 3 are infections. And in Vancouver, post HIV or HIV infection is a leading cause of COPD, certainly at our hospital. But around the world, tuberculosis or the residual effects of tuberculosis is a leading cause in developing countries. Severe childhood infections are another cause. Then we come to the well-known ones, which include cigarettes, cannabis, and increasingly evidence for electronic cigarettes and vaping. And then type 5 are environmental exposures, such as air pollution, wildfires, and occupational exposures. And I won't get into all of them, but the point of this slide is to show that COPD is more than cigarettes. There are genetic, host, and environmental factors that drive COPD from birth to senescence. And that's depicted here. So treatment of COPD and prevention of COPD is a lifelong journey and not a specific therapy in time. So when we think about COPD, the major endpoint is airflow obstruction or loss of lung function. And the way we measure lung function is through a spirometer, and we get this value called FEV1, forced expiratory volume in 1 second. And it's a surrogate for the health of our lungs. So when we're born with about 25% of our full lung capacity, and lungs grow during childhood and particularly into adolescence until age about 20 to 25. Thereafter, there's a slow decline in lung function to age 80 and beyond. And in normal individuals, it never goes beyond around 75% of the maximal lung capacity obtained in early adulthood. The typical age of diagnosis of COPD, because patients have to develop symptoms and do spirometry or lung function measurements. The typical age of diagnosis is between 55 and age 70. This is traditionally how we thought COPD developed in a given individual, that individuals develop normal lung function to early adulthood, and then they pick up smoking or some other environmental exposures, and then their lung function declines at a faster rate than the normals. So this is the typical way of developing COPD, at least that's what we thought. But in actuality, less than 1/3 of COPD patients diagnosed in older adulthood develop COPD through this route. The more common route is this, that the rate of decline of lung function is about the same as in normal individuals, but these individuals never reach their full maximal lung capacity, and maybe because of some event during childhood or some event in adolescence or in early adulthood. And the impact of those insults are profound because they persist throughout life. And as you can see, even with a normal decline in lung function, they will develop COPD between the ages of 55 and 70. And of course, you can have a combination of both accelerated decline and inadequate development of the lungs. And in these individuals, they may require lung transplantation or something dramatic or drastic at an early age because their COPD is so profound. So the workhorse of diagnostics is this simple machine called spirometer, and we perform spirometry, and we pretty much get all the information we need for diagnostics. We get a picture like this. This is inspiratory, expiratory, and looks good. And this is how we respirologists diagnose COPD. When the curve, this curve, is no longer linear, it's scooping like this, that indicates airflow obstruction or airflow limitation, and that in the proper clinical context would diagnose COPD. And then once the diagnosis is made based on this ratio of FEV1, forced expiratory volume at 1 second, to forced vital capacity, if it's less than 70, in the proper clinical context, that would be COPD. And then we stage the disease just as we would stage cancer. So going from stage 1 to stage 4, and that depends on the extent of your lung function. If it's well preserved, then we would say you have stage 1 disease. If it's really poor, less than 30% of predicted, then you would have stage 4 disease. And the reason this separation is important is not only are therapeutics different, but also your prognosis. In fact, the 5-year prognosis for patients in stage 4 approaches mortality of 50%. One, I think, important finding that our group at St. Paul's made many years ago was this, and this is a kind of complicated slide, but it tells a very important story. When we look at the lungs and measure the number of airways, and we call them transitional bronchioles, these are small airways, less than 2 millimeters in size, and compare them between the COPD patients denoted here and control, normal healthy individuals, you can see that even in stage 1, which we call gold 1, there is over 50% decrease in the number of airways. And we think what's happening here is during this asymptomatic or non-symptomatic phase of the disease, patients are indeed losing their airways. Why are they losing it? Probably through a destructive process that involves inflammation and other pathways. And then, of course, by the time you get to goal 4 or stage 4, you've lost 90% of the airways. And because we cannot regenerate these airways, once you're in these stages, it's very hard to recover lung function. And this explains why, even with the best therapies right now, we cannot recover lung function to a large extent. And of course, there are other changes than just loss of air or loss or destruction of airways. There are other things, and they're shown here. It's called remodeling, which is a very important component, which means that for a given airway, the wall thickens and the lumen narrows. So it's like breathing through a straw. And there are other changes, including mucus production and inflammation, that are now part of the COPD pathology, but also targets of new therapies. And pathologically, if we look at under the slide, this is a normal airway, what we call small airway, less than 2 millimeters in size. And these are the pathologic features. This is sputum or mucus here and here. And you can see why patients would have trouble breathing past this mucus plug because the lumen, the opening, is markedly compromised. And this is an example of airway remodeling where the walls are become really, really thickened, and that makes the opening very small. Okay, so I've shown you this slide before. This is how COPD patients develop COPD, we think. And because the loss of airways occur very early in the disease, if we really want to change the trajectory of COPD, then we have to do it before patients get even diagnosed with COPD, probably before age 50. And so the new research is focusing on disease modification in the younger persons. Okay, just shifting gears a little bit, there is increasing use of CT scans for a variety of different things, including lung cancer screening and COPD detection. So I show you examples of 3 smokers who all have normal or relatively normal lung function, but their CT scans are different. So this is a relatively normal CT scan here. There is a problem here, and that's emphysema. These are holes in your lung. And then this is a case of emphysema, but the hole is much bigger. And this is what we call a sagittal plane, and showing the emphysema here once again. And you can see that these holes are smaller than this hole. And this is just a cross section. Anyway, so you can have relatively low normal lung function, but have large holes in your lung, which we call emphysema. And prior to 2022, we didn't really have a diagnostic terminology for this condition. We now, the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, calls this condition pre-COPD, whereas the Lancet Commission just uses COPD. So according to the Lancet Commission, even if with relatively preserved lung function, if you have evidence of holes in your lung, then you have COPD. And why this condition is important is it may denote the early COPD that you saw previously. And if we follow these patients, as we did here for over 10 years, and look at the extent of emphysema on their CT scan and their lung function change over time, individuals with big holes in the lung have faster deterioration of their lung function over time than those with no holes in their lungs. So the holes in the lungs provide prognostic significance to these patients. So what is the current state of diagnosis of COPD? Well, we still think that symptoms are important. We don't want to just go around and have people blow into a spirometer and say you have COPD. That's probably not a very good approach. If patients have dyspnea, breathlessness, cough, or sputum production, then that will be the right setting to do spirometry and other diagnostic tests. And the menu of different diagnostic tests has increased significantly since prior to pandemic. So spirometry is still the gold standard, but there are other tests that have emerged or are emerging that can diagnose airflow limitation or emphysema, as we saw on the CT scan. And our group is particularly interested in using CT scan and MRI to diagnose early COPD, even before patients are very symptomatic. So I just show you some pictures of the new diagnostic tests: spirometer, body box, oscillometer, CT scan, and so on. And these things, some of these things are available clinically, some are still in research and development. One way I think clinicians and patients can quantify their symptoms, because symptoms are very subjective and even within individuals. So what you feel today may be a little bit different than what you feel tomorrow, even though your functional status may be the same. So it's best to use a standard questionnaire for symptoms, such as COPD assessment tests. And here we can ask about cough, sputum production, chest tightness, and shortness of breath, and sleep, and so on, and get a score. And if the score is above 10, that means you're symptomatic. If it's below 10, then you're non-symptomatic or asymptomatic. A simpler tool is called the MMRC dyspnea scale, and it consists of 1, 2, 3, 4, 5 simple questions. And if the patient says, I walk slower than people of the same age on the level, then this is abnormal, clearly abnormal. Anything above this is abnormal. Anything below this may be normal, may be abnormal. And I'll show you how we would use this in a clinic. So this is just to reinforce some of the novel diagnostic tests that are available. It all obviously starts with the patients. And capturing their symptoms are important in a standardized way, and then doing the right diagnostics to arrive at the diagnosis as soon as possible, and then institute therapies where necessary. Another, beyond the symptoms, clinicians are really focused on this thing called exacerbation, and so are patients. Exacerbations are lung attacks when patients become very sick and they have to go on antibiotics or prednisone, and sometimes they have to come into ER or hospital. And that the risk of exacerbations vary from year to year, but it also varies depending on the stage of COPD. So never smoke, don't experience any exacerbation. Some smokers do, even with normal lung function. But as you can see, as the stage increases, so does the risk of exacerbation, such that stage 3 and 4 patients on average, they have one exacerbation, one major exacerbation per year. Okay, so the Canadian Thoracic Society developed guidelines for drug treatment of stable COPD, and that was published in 2023. And I think it's very innovative and interesting. So this is a just a bird's eye view of the therapies available for COPD. And of course, physicians are focused on drug therapy or pharmacotherapy, but there are other important therapies or interventions such as education, smoking cessation, and rehab that should be considered for most patients, if not all patients with COPD, regardless of the stage of their COPD, going from 1 to 4, as you can see. The goal is to reduce symptoms, prevent exacerbations, and reduce the risk of mortality. These are all laudable goals and goals important for patients. So this is how pharmacotherapy or drug therapy is recommended by CTS. So mild and moderate and severe, and we'll get to how we would use this menu. As you can see, regardless of the severity, the cornerstone or the baseline therapy is a long-acting muscarinic antagonist. So that's in every single box here. And the reason for that is even patients with mild COPD, FEV1, 73% are predicted, so they are in stage 1 or 2 disease. If you give a long-acting muscarinic antagonist such as tiotropium, your risk of exacerbation drops by 40% over 2 years. This is a fantastic number needed to treat, really requiring only treatment of 8 patients to prevent 1 major exacerbation. And this is really a major finding and a major win for the COPD community. So let me just illustrate some ways we can use the CTS guidelines. So here's a clinical case, 67-year-old with COPD. His lung function, as measured by FEV1, is 55% predicted, and he's on ipratropium and salbutamol inhaler 4 times daily. And you can tell that this is a suboptimal treatment right from the beginning because the cornerstone is a long-acting muscarinic antagonist, not short-acting. He walks about 100 meters on the ground at a slow pace, and he's had no exacerbations. So if we go to the dyspnea scale, he's around grade 2. So what changes would you make? Well, going back to this menu, he would be a low risk exacerbation risk because he hasn't had an exacerbation the previous year. His FEV1 is less than 80% predicted, and MMRC is 2 or greater. So he would be in this yellow box. And so the starting pharmacotherapy ought to have been a long-acting muscarinic antagonist in combination with a long-acting beta-2 agonist. So an open airway is a happy airway in COPD. So, and there are plenty of drugs, inhalers, that it can accomplish this. So that's what we would recommend to Michelle. Here's Betty. She's a 73-year-old lady diagnosed 5 years ago. Lung function is about 59%. She's on a long-acting muscarinic antagonist, tiotropium, and occasional salbutamol. And she's noticed increasing shortness of breath, has to stop after about walking about 100 meters, and has had 3 exacerbations in the previous year. Okay. And so MMRC3, the 100 meters is a threshold, so she would be at grade 3. So what changes would you make going to this category? Now she's no longer a low exacerbation risk. She's high because she's had more than 1 exacerbation in the previous year. So she's in the green box. And so the starting therapy there would be a triple combination therapy: long-acting muscarinic antagonist, long-acting beta-2 agonist, and inhaled steroids. This can be done in 1 inhaler, or it can be done in multiple inhalers, and it states that it reduces also mortality. if they're on this and they're still having exacerbations, we would generally recommend a macrolide such as azithromycin at 250 milligrams per day, in addition to triple therapy. So this is how this menu is supposed to work and some of the science behind it. If you look at exacerbations per year, comparing two LAMAs and a LAMA-LABA combination, it just shows you the combo is better than individual components in reducing exacerbation. A lot of people are on inhaled corticosteroids, LABA combination, and in COPD, they're less effective than LABA-LAMA combination for exacerbation reduction and even symptoms. And this is well shown in this particular study called FLAME, where the risk of exacerbation was almost 20% lower in the group that used LABA-LAMA combination rather than LABA-ICS. And then now, for those who continue to exacerbate, triple therapy is the way to go, and it's far better than ICS-LABA, 20% reduction, and it's better than the individual components as shown here, and it also reduces mortality. That's why CTS emphasized that triple therapy can reduce mortality risk in COPD patients. Maybe I'll skip this because this is just a repetition of the previous slide. So the reason we like azithromycin in patients continue to exacerbate after triple therapy is this landmark study, which showed that use of azithromycin over 1 year at a low dose results in almost a 30% reduction in exacerbation compared to placebo. So it's a good add-on therapy. We now know that COPD, one of the primary drivers of COPD, and certainly COPD exacerbation, is inflammation. There are two types, or broadly two types of inflammation, neutrophil predominant COPD, and we target that by using inhaled steroids, azithromycin, and roflumilast, which is a PDE4 inhibitor. We don't really use roflumilast very often because it's relatively weak. There will be other therapeutics coming in the pipeline for this, such as canakinumab. The more actionable inflammation is called T2, and which is very common in asthma, but it appears to be operative in about a third of COPD patients. And the centrality in terms of cell is eosinophils in that, and it's driven by a different set of mediators. And there are now therapeutics coming on board that will target and reduce eosinophils and other type 2 inflammatory mediators. And just showing you some of this. This is not an advertisement. It's just to show that these therapeutics target these cytokines and that they will be, or some of them will be coming to market. In US, FDA has approved the use of dupilumab, which is a anti-IL-4, IL-13, the T2 antagonist. And the reason for that is that there have been 2 large therapeutic trials showing that use of dupilumab in COPD patients reduces the risk of exacerbation by about 30% compared to placebo and improves lung function by about 80 cc's. And this is a separate study which looks almost identical to the first study. So I'm sure Health Canada will soon approve dupilumab for the use of COPD, and there will be another biologic therapeutic. It's an injectable drug that will be available for COPD patients probably in 2025. So with that, I just want to summarize that COPD, the cornerstone of COPD diagnostic is still spirometry, but increasingly CT scans and full lung function measurements and other tools are being deployed for early detection of COPD. And there are many therapeutics now on the market and emerging into the market that will relieve breathlessness, reduce exacerbation, and improve the prognosis of COPD patients. And with that, I will stop and entertain any questions you might have.
Thank you so much, Dr. Sin.
Hand over the mic. Yeah.
So if anyone has any questions, we do have our chat box open, and we are ready to receive any questions you have for Dr. Sin. Thank you so much for that overview. Maybe I'll start us off with the question asking. Um, so in early on in your presentation, you described some early risk factors for developing COPD. So if people know for themselves they have some of these risk factors, whether it's early childhood infections or diseases like asthma, they start to notice some breathing symptoms. Um, when should they go in those early stages to talk to their doctor? What is that criteria or that tipping point where they should be thinking, maybe I should get this looked into?
Well, certainly if patients have symptoms, whether that's cough, and early on it's usually cough, intermittent cough, right? Pesky cough that doesn't go away even after an infection. Or you notice shortness of breath. And interestingly, the kind of patients who present with shortness of breath are athletes because they say, I used to run a marathon. I can't do that anymore. And that's very odd for me. Um, but breathlessness, because it's quite relative, is sometimes hard to discern whether it's pathologic or something else or physiologic. But any symptoms, I think you should see your physician. And still the gold standard is that spirometry and the breathing test. And it's relatively simple. It's relatively inexpensive. It's only about $10 to $20 per test. And if you think about all the expensive tests that we do, this is really cost efficient. And if that's normal, then, and you still have symptoms, as I've shown you, there are lots of tools now, both in the clinic and in the research setting, that can lead to earlier diagnosis. And the earlier you get diagnosed, the better you're off because you can modify your risk factors, preserve your lung function, and maybe even go on therapies that can modulate your disease.
Yeah, it definitely feels we kind of know in practice, however, access to spirometry is a really big limitation. And we know there are people, participants out there being labeled with COPD without having the spirometry done, that breathing test done. What would you say?
So, spirometry in some jurisdictions is hard to access. Totally get that. But part of that is just, I think poor delivery of service in that area. The way PFT labs are structured is problematic. Because spirometry itself, as you know, Jenna, takes about 5 minutes. There's no reason why we can't do 100 subjects or patients in a given day in a good PFT lab. So it's some of it is just the structure of the PFTs. We do need more facilities, and my pitch is if a facility can do ECG, they can do spirometry. And so we should have life labs and all these things have spirometer. And the reason they don't is they can't make money off of it. The physicians don't order enough of it. And it's a self-fulfilling prophecy. Well, there's not enough access, so we won't order it. We'll just throw around drugs or whatever and to hope for the best. That is a very bad approach in 2024. We need to drive spirometry use. We need to have PFT labs better organized and meet the demands of the community and just don't throw up their hands and say, well, we just have to do full PFTs that will take up, a full hour of PFT time and have, ECG facilities, including life labs, have spirometry on site.
Thank you so much. And that's a really good distinction for people to know. When we talk about spirometry, we're talking about a very simple breathing test as opposed to a pulmonary function testing, which is a larger capacity of tests. So really go back to your primary care physicians and healthcare workers and ask for that spirometry test to be done. We are getting some questions in the chat, and our first one is just wanting you to comment or elaborate on guideline recommendations. You mentioned that, for example, triple therapy, if you're at a high exacerbation risk, as part of the guidelines, and that there are many inhalers. That could be multiple inhalers or one single inhaler. So, what are your recommendations around multiple inhalers versus single inhaler devices?
Again, I don't take any money from pharma, so this is not an advertisement. But in general, it's easier to use one than five inhalers. And there are, both powder-based and aerosol-based triple or dual, bronchodilator inhalers. So I would encourage, I think, most patients to go for the three-in-one or two-in-one inhalers and find one that is right for them. Because as you know, inhaler use, that just the technique is very, very important. Inhalers are not pills. They're not that simple to use. So find an inhaler that you like, that you can operate on a consistent basis, and take it. And these drugs need to be taken on a daily basis, right? Some couple times a day. So, I don't have a strong preference, but I think in general, most people, like to use fewer inhalers, not more. And
Mhm.
whether it's powder or aerosol, some of that will depend on where your disease is, but also in terms of, where the site of disease, but also your ability to use these inhalers.
Absolutely. There's a question along those lines. This participant is finding, excuse me, the medications she uses for COPD, the inhalers are really irritating for her throat. She's wondering if there are any oral medications available.
Well, I would, before I address the oral medication, I would say, there are like 50 different inhalers. It may be that the one that you're on is irritating the back of your throat, but I suspect that you'll be able to find an inhaler that won't. So a lot of the aerosol base, if you use with a spacer, probably does not cause throat irritation. It's generally the powder or aerosol that is not properly used gives you the oral manifestations. So I wouldn't give up on the inhaler and just work with your doctor to find the one that works for you. As I mentioned, roflumilast and theophylline that are orally administered, but they're relatively weak as of now in terms of their ability to reduce inflammation or bronchodilate. There will be biologic injectable drugs probably in the market by 2025 that obviously are not inhalers and can be used systemically. There are some options for you right now, but the best option, is to find an inhaler that doesn't cause throat irritation but still treats the disease.
Thank you. Dr. Sin, you mentioned you talked a great deal about exacerbations in your presentation. So we have a question. So for uh, people who have been diagnosed with COPD, would a pneumothorax be considered an exacerbation?
Pneumothorax can be considered an exacerbation. For those who don't know, that's a hole in your pleural space and you leak through it. And of course, that would impair your breathing and you would probably have to come to emergency room or the hospital to get that fixed. It could be spontaneous in the sense that, just bad luck and, one of those things, but it can also be caused by an infection. Um, so it depends on the clinical situation. Not all pneumothoraces are created equally. The more important point there is if you have it, you need a chest tube probably to fix it. And then once you have it, even after it's fixed, you're more likely to get it the next time. So you may want to see a respirologist or a thoracic surgeon to determine whether a surgical option may be a better one to prevent future pneumothoraces.
Thank you. Uh, our next question is a common question in terms of asthma and COPD. So for people who have show this obstruction on the breathing test spirometry, who perhaps have a history of smoking, but also a history suggestive of asthma, things like ATP or childhood symptoms, would you choose to treat it more as asthma or more as COPD? And how does that work?
That's a very good question because it is a clinical conundrum. Even with all the best tests available and putting things together, there may still be diagnostic confusion about asthma or COPD. To a certain extent, it doesn't matter. That's what I would say. If you have airflow obstruction on spirometry, you need a bronchodilator of some sort. And if you have inflammation, as determined on a blood test or sputum or whatever, you need an anti-inflammatory. So what I would suggest is that, diagnostic labels aside, go with these kind of what we call treatable traits. And if you have airflow obstruction, you need a bronchodilator. If you have evidence of inflammation, either in the blood or sputum, you need a anti-inflammatory. And the best one so far, with the least side effect, is inhaled corticosteroids. So if you have no evidence of inflammation, then just bronchodilators. If you have evidence of inflammation, then inhale steroids and a bronchodilator.
Thank you. We
And keep
have
in mind, some of I mentioned the biologics. The biologics that are coming in for COPD are biologics that are now commonly used in asthma. So they target the same area. So your doctor, probably not your family doctor, but your specialist can determine whether a biologic would also work for you. And I have several patients on biologic, and they've done very well. But it has to be done in a specialized setting.
So, considering that, yeah, we do have these new targeted treatment options coming out for people. Um, when would you suggest our participants get referred to a respirologist, especially if
Um,
they're,
yeah, that's a very good question. I think you have to have significant airflow obstruction on spirometry. So probably, less than 70 or 60% predicted. In terms of COPD, asthma is different. You can have higher lung function than that and still be eligible for biologics. And you're on triple inhaler and maybe even azithromycin oral therapy, and you're still getting exacerbations or still quite symptomatic, I think that's the time to be assessed for biologics in COPD. Um, I just wanted to remind people that right now it's not available. We expect biologics to be available in 2025, so in a few months. Asthmatics are different, and asthmatics, the threshold for biologics are much lower, and it's because they respond much better to biologics than COPD patients. So, I would say for every 10 asthmatics on biologics, there's probably one COPD patient.
okay. Thank you. We have another medication question. So this participant is on a puffer called Trelegy because he was experiencing a lot of increased mucus production. And then he also started using Atrovent as well, but is still producing a lot of phlegm. Any suggestions in terms of next steps and maybe even a
Yeah, it's hard.
comment?
Obviously
Yeah.
that's a personal question, and it's hard to know without knowing the full clinical history and any diagnostic tests. Sputum production in general is hard to treat. So that's one. Two is if it's a real problem, getting a CT scan of the thorax is actually a good idea just to see where the mucus is. If it's buried deep within your lungs, a powder-based inhaler like Trilogy ain't going to reduce it. No, it's too far down, and the airways may be too plugged up. So there are, other inhalers that may be able to penetrate deeper. And when the biologics become available, that may be also a good indication for biologic therapy because it's injectable. It'll go to the deeper parts of the lung. So I think there are therapies on the horizon. And the other thing is you may have COPD and something else, right? So I'm hopping onto a call in 5 minutes to talk about COPD and a disease called bronchiectasis, which is actually fairly common. And that is associated with a lot of mucus production. So, and the therapies there are different. Um, they're aligned, but they're different than COPD therapies. So, you know, um, I can't give a direct recommendation, but these are some things to consider and work with your doctors to see whether the mucus can be. I mean, in extreme cases, I've brought patients in for bronchoscopy to get rid of all of the mucus through the bronchoscope, like the Dyson approach, right? The vacuum it out. And then, some patients respond quite well, for a year or so. So anyway, there are different approaches to these symptoms.
I really liked your saying in the presentation, open airways are happy airways. And so, yeah, there are a lot of non-pharmacological mucus clearance techniques too that could be helpful. Um, so we will maybe just do one or two more questions. And I think one of the interesting things for me from your presentation was this idea of pre-COPD and a lot of the airway loss happening before participants are symptomatic. Um, and then in lieu of this early kind of lung cancer screening and getting these CT scans done, we have a question that I thought could be relevant. And this person wants to know what lung nodules are and if that's a part of COPD. Is that something that could be picked up
Lung
from
nodules
CT
are
scans?
different than COPD, but COPD patients are at increased risk of lung cancer. So when we see a lung nodule, that's the most concerning part, right? Could this be lung cancer? And so there is, if you're in a high risk group for lung cancer, the province has a lung cancer screening program, which you should enroll into, and you'll get just like mammography for females of certain age, you can get quote unquote free CT scan on an annual or biannual basis. And if you have a nodule, they'll follow that up. So nodules are not part of the COPD spectrum or part of the disease manifestation. But of course, lung cancer is serious and can present at any time, especially in high risk individuals. So those things need to be followed, but that's not a sign of COPD.
Okay, thank you. And last but not least, we had a couple questions just in terms of COPD and COVID. Maybe just a comment on, those living with COPD and risks of associated with COVID.
Well, we've come through the worst part. I mean, there were two phases of COVID in the COPD population during the pandemic. One was patients who got COVID, caught serious COVID, especially the Delta variant. Many unfortunately passed away from respiratory failure. So COPD patients were at increased risk of severe COVID manifestations, and unfortunately, many passed away during the pandemic. The brighter side of that pandemic was people masked and were indoors. So there were fewer exacerbations. So the rate of exacerbation plummeted during the COVID pandemic. So we're past that. I mean, COVID still exists, but it's not as serious. The variant is not as lethal as the Delta or the Alpha or the original strain. I encourage most of my patients with COPD to get the COVID booster, and I got it myself, but I would understand if they had previous reaction to booster not to get it. But if they get sick with COVID early on, to take, there's now Paxlovid and certainly the antibiotics and prednisone for an exacerbation. So we are now considering COVID-related exacerbation in the same way we would consider, RSV or influenza-related exacerbation, steroids and antibiotics. The only difference is we might add Paxlovid early on if you fall into that time frame.
Thank you so much, Dr. Sin. Thanks for being with us here today and sharing your expertise and answering these questions. We really appreciate it. And I'm sure you've got a busy day ahead of
Thank
you as
you.
you
No, I just
celebrate
have
World
to hop
COPD Day.
onto another call.
Yeah.
So thank you so much. Bye-bye.
Thank you so much, Dr. Sin. He's a hot in-demand fellow today in World COPD Day. Next up, I will introduce our next speaker here. And our next speaker is someone with lived experience, and that is Kathy. And I will introduce her just as soon as we make sure we get her video going here. I can hear you, Kathy.
There's that cough. The one he was talking about.
COPD cough. Yeah. If you can hit on the bottom left, there should be a video button in the bottom left of your screen.
Start my
there.
video.
Start your video. That's the one.
There we go.
Perfect. So I'll just take a moment and introduce you. Thanks, Kathy, for coming. So Kathy is someone with lived experience. This is Kathy Sam, and she has been diagnosed with COPD, and she's come to share her experiences in living with this lung condition. I met Kathy online at our fitness club, which is our pulmonary rehabilitation maintenance exercise group. So I still haven't met Kathy in person yet, maybe one day. Kathy, thank you so much for coming here today to share your experiences. Yeah, it's so important for people to see that they're not alone in their experiences with COPD. So thank you so much for sharing, and I will let you take it from here.
Okay, like you were saying, my name is Kathy. I live in Maple Ridge, which is in the Fraser Valley. I've been retired since 2017. And when I did work, I was a bookkeeper in a nonprofit agency. And I'm not sure exactly when I was diagnosed with COPD. I first noticed some difficulties in my breathing back in the 80s. When I went for long walks or short hikes, I always had to stop to catch my breath. And it was more than just being tired. I was just like, I had to breathe. My lungs I was having issues. I went to, my doctor sent me for some breathing tests and prescribed me with Ventolin. And I'm not sure if it was Symbicort at that time or if I started it later. I was never diagnosed with anything, but when I used inhalers, it always helped. I kind of knew I should stop or at least cut down smoking, but my sole social group was around smoking, so I kept on going. Party girl. Fast forward to 2004, I knew my lungs were getting much worse and I needed to stop smoking. I went for another breathing test and my lungs were not at their best. The RT told me I needed to quit smoking. I told her I'd tried a couple of times without success and asked her to convince my brain that I must quit. I knew I must, but my brain wasn't telling me. She spent quite a bit of time with me and explained the effects of smoking and what it does to my lungs. She showed me pictures of good and bad lungs. Let's just say I got a real earful. I left there determined to quit, and I did. I was able to maintain the same lung functions for quite a while. I did notice in my last year of work, I was having difficulties lifting the heavier objects, but I could find ways to work around it. At work, I always got out of my chair every hour or so and walked around the halls of the building, go get a glass of water, a bathroom break. I tried to do as much movement as I could at work. Being on the OH&S committee helped. Our committee pushed for exercise and movement during the workday. To be honest, I didn't know I was helping my lungs. I just liked getting up and socializing. In 2016, when I retired, I was woohoo. Things started off okay. I wasn't moving as much anymore. In the summertime, when we went for walks, it started to become harder. It was easier to go for a drive, so I did, never realizing how it could influence my health. Hills got a little harder, so I avoided them. I was struggling going upstairs, so I made less trips, always accommodating my lungs. Then in 2020, one summer sunny afternoon or morning in Revelstoke, I woke up and struggled to walk down the hall. I had no air. It was so hard to breathe. We came back home and I went to see my NP. Whenever I started walking, my oxygen would drop to the mid or low 80s. She sent me to Emerge, and that was the start of life with oxygen. My respirologist told me to keep moving, go for walks, do not buy a scooter. He referred me to an exercise group that was running out of the hospital. It was a virtual group that was where everyone has a lung issue. Some use oxygen, some didn't. I could see other people were dealing with lung disease, but most important, I wasn't alone. It was a great group of people that came with a wealth of information on personal experiences. The group also has an education portion which teaches us what lung disease is and how to live with lung disease. I've since joined another exercise group that has been amazing. Popular has not only been there with my exercises, but they guided me through rougher times. It's so easy to be a couch potato when things aren't going well. Lung disease can affect our mentality as well. I was going crazy with anxiety. Popular just happened to have a speaker on anxiety. Good timing. I was able to use the tools of the speaker suggested, and it really helped me. Last summer, I got influenza A, and it knocked me down. I spent 8 days in the hospital. That was 3 months ago, and I'm still in recovery. I'm taking an easier exercise class and to help bring my lungs back to where they were. I even started using a walker when I go for walks, and that was tough. I always have to be aware of crowds. Every time I plan something, I often have to wonder how or worry about, is there going to be too many people there? I need my space. I need lots of room. I've learned the hard way that you cannot ignore or accommodate your health. In living with COPD, there are two things that are a must for me. One are vaccinations. Having the flu, getting that flu and kicking me down was a good sign. So always get my vaccinations. And the other one is exercise. Whenever I stop exercising, it slows me right down and I start over again. So that's it.
Wow, thank you, Kathy. That was so great.
Pulling
on my heartstrings. I am impressed you got through that so well. Oh my gosh. You know what? I think that the way you tell a story is so relatable. Yeah, if anyone has questions or comments, please feel free to post them in the chat.
Yeah.
I think it's wonderful for people to hear, real life, day-to
questions and guide me through it.
Yeah, getting help is for sure so important. And we know in our healthcare system that some people do have trouble finding, specialists or health practitioners that they know and trust to work with. So if you're one of those people who doesn't have a family practitioner, please keep searching. It's so important to get somebody and reach out for other help. We're here at Popular Pulmonary Wellness that we can help you reach out through any means that you can, because getting support, like Kathy said, it can mean the world. Yeah.
And I've learned so much from that group, just with people, and it's just like, okay, what do I do? And all of a sudden somebody will jump in and just tell me, this is what happened. And I'm like, ooh, okay. So yeah, it's been good. It's been good.
Yeah. Yeah, I find other people living with the condition are sometimes the best people to help with all those, little tips and tricks about what they've done to
Mhm.
manage. Yeah.
Yeah, yeah.
Yeah.
And
Awesome.
the
Yeah.
education
BC
is
Lung.
always, no, you can't learn too much. Every time and I've heard some of it before, but it was just like, oh, okay, I forgot about that. I forgot about that. And yeah.
Yeah. And actually what you're mentioning too is that speaker about, anxiety and that mental health piece is the same speaker we've got coming today. So that was a great
Oh, good.
foreshadowing. Yeah. So Dr. Sarah Bellefontaine will be speaking today. So all these little nuggets
Oh,
that
wonderful.
Kathy's
Yeah.
talking about, you're going to get them too if you just stay online with us here today.
Yeah. Oh, it was
Yeah.
wonderful. Yeah.
Yeah. Yeah. There's a lot of comments in the chat or a few comments coming through just saying like they can relate to your story and echoing your sentiments about how important exercise and moving is, even just walking around the house. Yeah.
Oh, definitely.
Thank you,
Definitely.
everyone, for your comments.
Yeah.
Amazing. Thank you, Kathy. I
You're
will
quite
say thank you.
welcome.
Thank you for coming. That was very valuable. People are still typing in thank you in the chat box for you. So thank you so much. That was a story well told.
Okay. Thank you.
Thank you. Okay.
Right.
All right. And next on our list, drum roll, is Jenna and myself. Uh,
As we set up our presentation, we will have a break coming up after our talk, but feel free to take a moment just to stand and stretch and do what you need to do to feel comfortable. Our presentation, we'd like it to be really interactive. We'd like to hear your comments and questions as we go through. So feel free to keep that chat box open. So we will be talking about COPD exacerbations. And it's important to note not only recognizing when one is happening, but we're going to be talking about how to treat them. Um, the first thing to kind of delve into is this very long, hard to pronounce word exacerbation. And there's lots of different ways to call this event. And Dr. Sin alluded to that in his presentation a little bit. He called them lung attacks. They also can be called worsenings or flare-ups. Um, the most important thing, though, is for you to pick the term, the word for these events that you resonate with, that you feel this is a term that you can use and you feel comfortable using, and then expressing that to your healthcare providers. So you can call it whatever you like: exacerbation, lung attack, flare up, worsening. But do talk to your healthcare providers about it and make sure you're both using the same terminology that makes sense to you.
And we'll do a quick land acknowledgement. So we'd like to acknowledge that we are on the lands of the unceded ancestral territories of the Coast Salish people here today, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And if you'd like to share the lands on which you live, work, and play, please feel free to post that in the chat. It's always interesting to hear where people are joining us from. And our disclosure of financial support and conflict of interest. So we are Poplar Pulmonary Wellness. We are a private business offering respiratory care services, and we mitigate this bias by presenting research-informed data, and our purpose is to educate and offer support for those living with chronic lung conditions.
So, what we're all going to try and get out of the session today. So, we're going to define what a COPD exacerbation is. And more specifically, we hope by the end of this session, you know what it is for you, because it is an experience that could look a little bit different for everyone. We're going to learn about the risks involved in having an exacerbation. We're going to discuss the importance of the ask and tell approach. So this is an approach we're going to use to try and talk about exacerbations more and report them to our healthcare providers. and we're going to review managing an exacerbation using a COPD action plan. So we'll go to the next slide, and we want to hear from you. So those of you participating today in the chat box, can you let us know, have you had an exacerbation, flare-up, worsening lung attack in the last year? And if you did have one, what were your symptoms like? If you wouldn't mind sharing what you experienced, what symptoms you noticed. And we're also curious to know, those of you listening, whether you have a COPD action plan, a written action plan. So please feel free to share that in the chat, and we'll come back to those answers in just a moment. So what do we know about exacerbations? So from the BC COPD guidelines, they characterize an acute exacerbation of COPD as a worsening of symptoms. So shortness of breath or dyspnea, increased coughing, and often increased mucus production or sputum purulence. So that often refers to the change in color of your mucus, perhaps due to infection. And these symptoms, again, which can be different for everyone, they persist. So they're not something you experience. It's not just one bad day. It's something that persists for a little while, often over a 48-hour period. And so we're hearing from some of our panelists or some of our participants here that yes, some of you do have COPD action plans. Some have an action plan but haven't experienced a worsening in this last year, which is great. So continue to type in the chat and let us know where you're at in terms of exacerbation. And we'll go on to the next slide. And so we really want this picture to stay with you if it can, and that's tame the flame. And this is because often us respiratory educators describe exacerbations as fire because it's often associated to inflammation. And this inflammation can be happening locally in the airways of your lungs. But with an exacerbation, it can also be happening systemically, so in other areas of your body. And when you think of this fire, when you think of inflammation, we want to treat it. We want to treat it early, and we want to treat it completely. So we don't want to just sprinkle some water on the fire and cross our fingers and hope for the best. We want to take some dedicated actions to get this fire under control. So part of the first steps is just noticing that there is a fire. And this is noticing that change in your baseline symptoms. So some of you living with your COPD, you might have symptoms you experience daily, whether it's coughing up phlegm every morning, and it might be a certain amount and a certain color, and that's normal for you. So when we talk about exacerbation, we're talking about a change in those normal baseline symptoms. So keep note of what your symptoms are like. Be vigilant. Sometimes we might know what triggered the change, an environmental reason like forest fire, smoke, or infection, but sometimes we don't know what's triggered the change. And so then it becomes extra important to notice these changes with your symptoms. Along the line of triggers, sometimes we can remove ourselves from the trigger when we know what it is. If it's, for example, a dust exposure, something like that, a gas exposure. Sometimes we can remove ourselves, but again, sometimes we don't know what the trigger is and we don't know how to do that avoidance measure. So again, noticing these changes in symptoms are going to be your best tool. When we treat this fire, we want to make sure that we use our plan. So for example, we want to, much like in a building where you live, you might have a fire safety plan, or it's mounted right by the elevator where the exits are. Similarly, we want a written plan to help us navigate this fire, and that's going to be our COPD action plan. We want to report these fires as well. We want to notify the fire department. So do tell your healthcare providers when you experience an exacerbation so that it can get documented and reported. And then in a couple slides, we'll go through some treatment to put out this fire entirely. We'll go to the next slides. And thank you so much for keeping those comments coming in the chat. So when you have an exacerbation, we heard from Dr. Sin that this really increases your risk. You know, the reason why we talk about this is because each exacerbation you have increases your risk of mortality, especially if that exacerbation is a severe one where perhaps you end up in hospital because of it. Exacerbations reduce your lung function, and Dr. Sin showed us that as well. It reduces your exercise capacity, and Kathy shared that a little bit too. So it impedes your ability to do your everyday activities, and all of this can contribute to a worse quality of life. Dr. Sin showed us that having an exacerbation puts you at risk for another exacerbation. And we watch that closely, and we want to make sure that when you do have one, that we try not to have another one in that year following. And so that's why it's really important to report these worsenings and let your healthcare providers know. Let's get it documented. Because the way that we treat your first one is going to help us in terms of treating any future ones. The more exacerbations you have in a year, the greater your risk. And exacerbations can last a long time, and Kathy shared that with us too. And so it's been noted that they can last as long as 8 weeks, for example. Exacerbations, there are different severities to them. And perhaps you might be thinking to yourself of really bad ones, maybe where you ended up in hospital, but we need to remember there could be mild exacerbations as well. And often the severity of your exacerbation, the worsening that you experience, isn't often known until after the event, because then we look at, okay, well, how did you get back up to a baseline or get past the exacerbation? And we look at the type of treatments that were used. But for mild ones, sometimes it's just using some extra bronchodilators, so some extra quick relief puffer. And those are a mild exacerbation. Those need to be known. Those need to be documented. So do go to your physician and talk about it if you're noticing that you're using extra of your quick relief puffer. Some exacerbations are moderate, where we bring in the really big hose to tame that flame. And that's often prednisone, oral tablets, and we'll talk about that in a little bit, as well as perhaps an antibiotic. Some exacerbations are severe, and despite your best efforts, you need help. And that's when you go to emergency or hospital. And we really try and do early initiatives to prevent heading into an acute respiratory failure, but those can happen as well. We'll go to the next slide. So in terms of treatments, so we treat again based on the severity of the exacerbation. Remember, each treatment of an exacerbation is add-on. You're adding on to your maintenance plan, whatever that is for you. And for many of you, that's maintenance inhaled puffers or inhaled medications. As we mentioned, in a mild exacerbation, you might use bronchodilators. They're often your quick relief blue puffer. You might be using the device that you use that bronchodilator with might look different. So it might be an MDI or spacer device. Of course, if you're using an MDI, we always recommend the spacer. Those with severe disease, depending on your inhaler technique, maybe you are using a nebulizer during exacerbations, knowing that you're quite more symptomatic. The best way to treat those airways is to get the medication directly into those airways. And so technique is very, very important. We know 50% of people are not using their devices correctly. So get your device technique checked often. Feel confident in how you're taking those inhalers on a regular everyday basis so that when you are experiencing an exacerbation and you are more symptomatic, you feel confident that you're getting the medication in the time that you need it. We learned that moderate exacerbations require perhaps prednisone, the big hoses coming in to absolutely tame that flame. Often they're prescribed at an equivalent dose, maybe somewhere between 40 milligrams for about 5 days. It's often tablet medication at this point. The reason why we use prednisone is because studies have shown it can improve our lung function, or FEV1, and it can improve our oxygenation and reduce the time needed to recovery as well as the need for hospital. If the exacerbation is infectious in nature, you're feeling unwell, perhaps you have a fever, perhaps you're noticing those mucus changes, so more mucus and a change in color, a darker color often, you might be prescribed an antibiotic. And the antibiotic is often for 5 days, and it's to treat the classic signs of a bacterial infection. So make sure you take your full course of antibiotic, even if you're feeling better, just to prevent any antibiotic resistance.
Excellent. Do we want to take a look in the chat? Were there any more comments about these unreported exacerbations in there? I can't see the chat box, though.
Yes, we do. So we have some participants saying they do have an action plan. Some have had exacerbations in the last year requiring hospital visits or hospital stays, and then came out of those exacerbations feeling more shortness of breath, a bit harder to catch the breath. For some people, they know that there's a change when they actually feel shortness of breath or pain in the chest. And we certainly hear that people experience chest tightness or chest pain. And chest pain is really important to not ignore. We're going to go through an action plan in just a little bit. There are differential diagnoses to a COPD exacerbation. So again, another reason why it's really important to see your healthcare providers when you experience those change. And then I talked about that the taming the flame, that inflammation can be local in the lungs, but also systemic in the body. And we've learned a lot over the last year that having a COPD exacerbation puts you at higher risk for having cardiovascular events like a heart attack or stroke. And that's because of inflammation happening in the body in those other organs. So chest pain can certainly be a sign. Certainly see your doctor and get assessed. And then some other people sharing about the phlegm gets thicker and it starts to change color. That's very a classic sign. So thank you so much for sharing.
All right. So with all of this information, this wonderful information from Dr. Sin, the experience shared from Kathy, and all this information from Jenna, you might feel like you're swimming in this pool of information and feeling a little overwhelmed. And I see in some of the earlier questions with Dr. Sin that people have questions about, your specific situation with your inhalers. So coming here now, I'm going to explain some more simple advice, things you should do should you think you have an exacerbation or should you have an exacerbation, and how to keep your lungs healthy using your COPD action plan. So one of those things is the ask and tell approach. The other one is the action plan, which we'll get to in just a moment. And so the ask and tell approach is on your care provider and people living with COPD. So the ask is on the side of the care provider. And so they should be asking you about changes in your symptoms since they last saw you. And they need to do this to rule out differential diagnosis. So we've been talking about some of the other causes that can cause shortness of breath or chest pain other than COPD. And it's important to make sure that your COPD is managed, but also any other conditions are managed properly, such as a pulmonary embolism, angina, or congestive heart failure. Your healthcare provider needs to determine why this change has happened, and this to adjust treatment. So there might be some tests such as viral testing or growing a sputum culture so that they can make sure you're on the correct antibiotics or antivirals. Updating your action plan. So every time you have an exacerbation or a flare-up, we need to maybe need to relook at the action plan and make sure you're still on the right one for your symptoms and your severity of lung conditions. The tell approach is from the side of the person living with COPD. And so we can't leave the onus all on the care providers because things can get lost in the mix. So do take charge of your own health here and tell your healthcare practitioners about any changes you've been experiencing since you last saw them. And this can help define the severity of any exacerbations or flare-ups that you've had. So we can classify that based on the treatment. It gets documented. And documenting exacerbations is so important in determining your future care plans. So we need to make sure you're on the right treatment for your condition, and how many exacerbations you've had does help to define the condition that you have. And we want to make sure that you're getting the right treatment and that your symptoms are improving. And so when we look at some data here, there was a multi-country study that had 857 participants, and they were looking at the under-reporting and under-treatment of exacerbations. And this study found that less than half of the participants contacted a healthcare practitioner when they had an exacerbation. Less than half, which means it's definitely getting under-reported, which means their treatment could be affected. And we're finding that they are getting less treatment than they should be. So do tell. And if you're a healthcare provider, do ask. Well, let's move on to action plans here. So action plans are your guide to managing your chronic lung condition. So we want a COPD specific action plan, and this tells you what to do to manage your everyday health and what to do when you have a COPD flare up. So it helps you and your healthcare team to quickly recognize and treat flare-ups so that you can return to a stable state as soon as possible. It is a document that is created by you and your specific healthcare team, and it is written down. It needs to be written down and kept handy. And in a large review, it was found that COPD action plans with short education reduced in-hospital healthcare utilization. And so we're going to go over action plans today. We're going to give you that short education with the goal of reducing healthcare use and reducing your time in hospitals and the amount of time you visit a hospital. So COPD action plans, this is your tool, this is your guide. This is information coming from your healthcare practitioners to help you stay healthy. The one that we use is from, the one that we recommend is the one from the BC Ministry of Health and the Doctors of BC. There are other templates out there, so if you have one that's not this particular one, that's okay. But if you don't have one, we do suggest this one because it's the one that most healthcare practitioners in BC will already be familiar with, and it helps to ease the communication in that sense. And we do want you to keep your COPD action plan handy and bring it with you to your medical appointments, especially if you're going to the hospital and seeing healthcare practitioners that are not familiar with you and your situation. So I know you can't read this slide. That's not the goal here. This is the action plan that we recommend. And I just want you to take a quick sort of at a glance view here, and then we'll dive into each of the sections and we'll read through them together. And so you can see that there are 3 big zones with this action plan, and it's like a stoplight with the red, yellow, and green lights. So briefly, the green zone, green is good. You want to be in the green zone. This is where you're doing all of your management techniques to keep your lungs healthy. Should anything change, you may be finding yourself in the yellow zone. The yellow zone is action zone. This is the caution light. We're only here for a short period of time. So this is an opportunity to take action and improve your situation. The red zone. The red zone is the danger zone, and this is where you do need to go and get medical help. So should you find yourself in the red zone, you do need to take action right away. It's important to note that if you're in the green zone, you don't have to go to the yellow zone and then the red zone. It's not progressive in that way. So you can be in the red zone and suddenly find yourself, sorry, you can be in the green zone and then suddenly find yourself in the red zone. So it's not a, going green, yellow, red, yellow, green, or anything like that. So you wake up in the morning and think about your symptoms and classify yourself which zone you're in and take the action according to that zone. So let's dive into each zone. Let's start with the green zone. So this is the green zone, and you can see at the top that it describes some of the symptoms you would be having that tell you you're in the green zone. So your breathing problems haven't changed. So this is normal for you. You may have the same amount of shortness of breath as usual. You may have some cough. You may have some sputum, but all of this is your normal, your baseline. And you should be able to do some exercise and doing your daily activities as usual without having any trouble sleeping. So during the green zone, there's still things for you to do to maintain your lungs, like taking your inhalers. So taking your inhalers, filling your prescriptions regularly before they expire, and having your inhaler technique checked about every 6 months to make sure you're taking it properly and getting the most out of your inhaler. You should be managing and monitoring your mucus. So you might be doing some mucus clearance techniques like a huff cough or active cycle of breathing here. Should be exercising regularly and eating a healthy diet. Stay up to date with your vaccinations when you're in the green zone. Wash your hands regularly and wear a mask at times of higher risk. So in the green zone, you want to stay alert for changes. And you see this yellow cube here in the green zone. So we're watching for a flare up so that we can catch it early and treat it soon. So maybe you've got a cold or a flu going. If you're feeling run down or tired, maybe you've been exposed to a trigger like smoke or air pollution. Maybe even weather changes can trigger your breathing to change. And especially mood. So sometimes when you're feeling stressed or anxious, that can knock our immune system down a little. So all of these things are things that might take us to the yellow zone. So here in the yellow zone, this is the time to take action. So we've identified a flare up, at least a mild one here. And things you might notice is that you're feeling short of breath more than usual, coughing or wheezing more than usual. Your sputum might be increased. So you might have more sputum or mucus. It might be thicker and it might have changed color. So it could be yellow, green, or rust colored. You only need to have one of these symptoms to be in the yellow zone. We're not looking for all of these symptoms. So in the yellow zone, this is where you and your doctor or your nurse practitioner will come up with a plan that is specific to you and your lung condition and your symptoms. So you will probably have some inhalers prescribed to take regularly. In the yellow zone, you might have extra inhalers, like a bronchodilator, to use when you're feeling more short of breath. Or you might have a different dose of your regular inhalers to take. You may have some prednisone. This is an anti-inflammatory steroid, or antibiotics to treat an infection. And it should be very clear to you with your healthcare team which one of these things you should be doing in your yellow zone. There's also a spot for other. So this could be perhaps doing a COVID test or a prescription for Paxlovid. Um, and you're still doing all of the things in the green zone, plus these things in the yellow zone. And in the yellow zone, you can only be here for 48 hours. So within 48 hours, you should, hopefully, you're noticing some improvement. If you're noticing some improvement, then great, it's working. If you're not noticing improvement or you're getting worse, then we're going to go to the red zone where we need to get some medical attention. So the red zone is the danger zone, and you do want to take this seriously. Symptoms that tell you you're in the red zone are feeling extremely short of breath. So if you're breathing pretty quickly and you can only take a few words in every sentence, that is extremely short of breath. So if you feel extremely short of breath, if you're confused, agitated, or drowsy, or you have sudden chest pain, you need to get help right away. All of these symptoms can be caused by COPD, but they can also be caused by other serious medical conditions, such as uncontrolled angina, blood clots in the lungs, a stroke, or even a heart attack. And an extreme COPD attack like this also does need to be treated right away. So you may have been in the green zone and suddenly found yourself here, or you may have been in the yellow zone doing all your best efforts to get back in the green zone, and you might still find yourself here. Um, it's okay. Try not to panic. The goal with the red zone is to get you help. So as healthcare providers, we want to help you, but we don't know when you need the help. And so the onus is on you to call for help and let us know. So there are extra things that we can do for you if you do come to the hospital. And that's the goal here, is to get your breathing back on track and get you feeling well. And that is the whole point of the action plan, is to empower you to make some changes and make decisions about when to get help and when you can treat safely on your own at home using the prescriptions and plan given to you by your care provider. So just as a summary here, we want you to know, to be able to identify what an exacerbation is and know when you're having one. Even if it's a mild one, it should be documented. We want you to tell your healthcare practitioner about it. So write it down, put it in your notes when you're next going to be having a visit so you don't forget to tell them. Just call them right away, book that appointment. And get an action plan if you don't have one already. This is a very important document. It can help to relieve anxiety knowing that you have a plan in place, and it can help you make the right decisions in moments of concern and change with your breathing. And then follow your action plan. Keep it handy. Let other people who are involved in your care and your family know about your action plan so that they can help you as well. And if you have any questions for us, we're happy to tackle those if you'd like to post them in the chat box.
And we've been posting some of the links as you've been talking, Tina.
Thanks.
So we do have the Doctors of BC link for that action plan. There was some discussion about perhaps getting it onto the BC Lung website, which we will see if we are able to do that. The BC Lung website also has some great videos there, including an action plan video. So we put that link in, and a link to your first resource that we're showing on the slide here from BC Guidelines, which is a good summary for all of you, some different aspects of living with COPD and some resources, quick links to resources. So do be sure to click these links in the chat box, open them separately in your browsers before the end of today's session, so you've got them handy. We will feel free to, like Tina said, post any questions in the chat. We are running just about 10 minutes over. We do want you all to have a break. So why don't we take about a 7-minute break, stretch your legs, use the washroom, grab some water, a snack. Those that want to hang on the line, we're going to lead you through a quick stretch session. Those that want to walk off and take your break, please do that. And we will be happy to introduce our next speaker, Dr. Sarah Bellefontaine, at 11:50.
And I'm just gonna get a little movement here, setting up. Do we want to put some music on perhaps? Well, do we have the power?
Do we have the power? That's a question. Let's see.
To
We
put on
might.
some music. For 7 minutes here while we move and breathe.
Oh, think. Oh, no, we don't have the power.
We don't have the power. Okay.
No.
We're gonna move and breathe without music here. All right. So I will guide us through some gentle movement. Still see me here? Gentle movement. moving and stretching. So feel free to join in. This is up to each person based on your fitness level and your breathing, but we'll keep this a little bit gentle. I will show this in seated, but you can feel free to do the first part in standing if you'd like. And we'll just do some gentle movement together for those who would like to stay on. We'll assume not everybody's left this and gone to the bathroom. So we're just going to get some gentle movement. If you'd like to move your feet, we're going to do forward heel taps. So I'm just tapping my heels forward. You could also do marching or walking on the spot. You could do this in standing or in seated. If this is too much, that's okay. We're going to do some upper body stuff. So feel free to do lower body and upper body or just one or the other. So I'm going to keep my heel taps going. I'm sitting up tall or you're standing tall, belly button to spine. So got some tone in the core here. And we're going to start with some shoulder shrugs. So just shrugging those shoulders right up to the ears, really tense them up and then release them down. And so we're going to do this a few times. Really shrug them up to the ears. Try and touch your ears there. Tense them up. And then when you relax, you should feel further relaxation than you did before we start this. So keep it going. A few seconds of the shrug and a few seconds released. And as you do this, you might want to take a big breath in as you bring your shoulders up and exhale through pursed lips as you bring your shoulders down. When you breathe in through your nose. Maybe you've got oxygen on, getting nice oxygen there. And inhaling through the nose to add some moisture and humidity and filter the air. 2 more shoulder shrugs. Big breath in. And exhale. Last one together here. Shoulders up to the ears. Big breath in. And let it go. Perfect. Keep those legs moving if you're up for it. Let's do shoulder circles. So we're just going to bring the shoulders rounded forward, even round your back a bit. Up to those ears again. Slide the shoulders down your back, tensing between your shoulder blades and actively pushing those shoulders down. Perfect. So just keep going. A few more shoulder rolls in this direction. Keep your breath flowing. Nice deep belly breaths if you can. And let's go in the other direction with the shoulder rolls. So go up the back, up to the ears, rounding forward and down. Doesn't need to be quick here. We're just activating the muscles in your chest, in the thorax, and getting a lot of nice movement in the thorax while we do this. So kind of loosening up those spaces between your ribs, giving your lungs lots of space here, giving them the freedom to move. One more shoulder roll in this direction. And relax those shoulders down now. Great. Let's get some arm circles going. So nice and slow, gentle arm circles. If you've got any shoulder issues, you don't want to feel any pain or pinching here. So just be sure to move your shoulders in a way that feels good to you. If anything's feeling off, any shortness of breath or pain or anything, please do stop and just rest and breathe. Speaking of breathing, keeping that nice pursed lip breathing going. So we're inhaling through the nose and exhaling through pursed lips. Going the other way with the shoulder rolls now. We're going to try and inhale as we bring the arms up. And exhale as you bring the arms down. So move your arms at the pace of your own breathing here. Coordinating your breath with movement can feel really good, bringing you into the present moment here. Love it. One last arm circle this way. And relax those arms down. Give them a little shake. Awesome. All right. We're going to switch up the legs here. So if you're doing the leg portion, we're going to do side toe taps. So if you're in standing, just tapping your leg out to one side and then the other. keep on going with this. And we're gonna do punching forward with the arms as we tap out the legs. A little brain exercise here. Coordinating the legs with the arms. And keep your breath flowing here. Don't forget to breathe properly. So you can slow this down or speed it up according to your shortness of breath. So if you're feeling short of breath doing this, maybe stop moving the legs. That can bring more exertion on. Or if you're not feeling like this is enough for you, you could go faster, or you could go into standing and do this. Be sure to have a chair handy for balance. Maybe you're exhaling as you punch those arms forward. Maybe one hand you inhale, maybe the other hand you exhale. I see we're getting some questions in the chat there. We're okay?
Yeah, we're okay. So just a question about the leg movements.
Yes.
It's just to add a little extra intensity. So getting the breathing rate and heart rate up just slightly, if that works for you, and using your shortness of breath as a bit of a guide. So these are the types of things that you learn in pulmonary rehab, how to make movements feel good for your breath, get a little bit of a workout in while still managing your breathing, your shortness of breath. And so hopefully you all are feeling warm. You've either joined us in some movement, or you've been able to use the washroom and have come back to us. We're going to wrap things up in about 1 minute with this stretch, and then we'll head on into our next segment.
All right, so we'll calm down with our moving here. We'll slow the legs, rest the arms. We're gonna do a little bit of a stretch here. We'll do a seated cat-cow stretch. So this is a nice thoracic stretch, or like a rib cage and a back stretch. So seated cat-cow, we're gonna do, imagining like you're walking through a door frame here, and bring your arms back. Maybe even extend your fingers, wiggle your fingers straight. If you're looking for more, you can even flex your wrists back. So opening the chest, opening the front body, lots of room here for the belly to move. Nice big breaths into the belly here, maybe even looking up to where the ceiling meets the wall. Take a nice big breath in here, and then we're gonna round forward. Arms are crossing over. Maybe you can even give yourself a hug here and bring your chin to your chest. So we're rounding the back here, making a nice C shape in the back. Bring that chin to a chest. This should feel good. If it feels a bit tight, back out a little bit. And we're pulling apart the shoulders and the shoulder blades, opening the back body. Put your exhale here. And then we'll come on back up to seated position as we're feeling a little looser and a little more open there before we carry on with our next speaker. It's one thing after the other today, try to get everything in for you.
So we just had a question about exercise resources and things like pulmonary rehab. I put the resource list from the BC Lung website. There are lots of options out there. So have a look at that list, choose the option that feels right for you. And so Dr. Sarah, are you there?
In
Yes,
the
I am.
online. Oh, she's
Yes,
there.
she is.
Hi, Sarah.
Hi, Sarah.
Hello.
All right, nice to see you. We can hear you and see you well. So everyone, if you're ready to carry on this journey with us, we would love to introduce Dr. Sarah Belfontaine. She is a clinical health and counseling psychologist. She provides evidence-based therapy for adults dealing with anxiety, depression, post-traumatic stress disorder, interpersonal issues, grief, and life transitions. She has a special interest in supporting individuals with chronic health conditions, just like COPD, and helping those navigate pregnancy and postpartum challenges as well. She has an experience across various clinical and hospital settings, including private practices, family health teams. She's based out of Ontario and several major hospitals. She currently works at her own practice called Four Wing Psychology. So thank you so much, Sarah, for being with us today. And you're going to help guide us through some discussion around anxiety and depression when living with COPD.
Yes, very much looking forward to that. So I'm just going to hopefully get my lovely little presentation set up for everybody, if I can do that. Just to have a little bit of a visual. Bear with me for half a second. Right. And
Coming up there. There we go.
Beautiful. Okay, so here we are. So thank you so much for the introduction. So today I'm going to be talking to you about anxiety and depression, which do correlate quite a bit with chronic lung conditions, and in particular COPD. So we'll be talking a bit more about that in particular. So what we're going to be covering, I'll go into a little bit about who I am, I know Janet gave you a little bit of an introduction, but I'll give you a teensy bit more info. And then we'll look at some of the impact of chronic lung conditions rather. We'll look at what anxiety is and how COPD and other chronic lung conditions can interact with anxiety, and then also the same for depression. And then I think the most important part is kind of how can we make that a little bit easier? What can we do to help that out a little bit? And then if anybody has any questions, I am always open to questions. I love questions. So I just wanted to start off with a little bit of a quote that I think gives a little bit of context to why it's so important that we are here talking about this. So I came across this quote, sometimes the most important thing in a whole day is the rest taken between two deep breaths, which seems like such a basic thing and such a, easy thing to do, except if breathing is a challenge. And then that becomes really challenging and really difficult. It maybe takes a little bit extra energy to be able to get to the same result. I think it's important for us to not take for granted the ability to take those 2 deep breaths a day, but also then to find ways to put in place things that are going to help us to feel better on a daily basis. So who am I? Why am I here? I'm, like Jenna said, a clinical health and counseling psychologist. I own a private practice in Ottawa. I do have experience working with a number of chronic health conditions. It's one of the things that I love most about what I do, and so I do it very happily. As a health psychologist, that's kind of where that knowledge comes in. So I work a lot to help people adjust to challenges that they might be facing in terms of their chronic health, and also work to better their mental health given the constraints that their physical health might be placing on that. I also do have personal experience with lung conditions, so that helps to guide me a little bit in terms of a little bit of understanding about what that might be like. So in terms of the impact of chronic lung conditions, certainly I'm preaching to the choir here. There's a huge impact. So it has a big impact on quality of life. It impacts pretty much every aspect of your life. When you can choose to do activities, what activities you can choose to do, for how long I'm able to do these things. And so understandably, that can sometimes impact our mood in terms of bringing about things like anxiety and depression. So having a chronic lung condition such as COPD can impact how we feel about ourselves, how we feel about our life in general, our satisfaction with our life. And certainly the impact of stress can have an impact itself on our breathing, which we're going to talk a little bit more about. So what is anxiety? Anxiety is really a reaction that our body is having to something that it perceives as a threat. So if we think back to caveman days, a saber-toothed tiger is, chasing me into the woods. My body's going to react in a couple different ways, depending on a bunch of different factors. Generally speaking, though, the two main ways are fight or flight. Either I'm going to turn around and charge at the saber-toothed tiger, or I'm going to, hightail it out of there as quickly as I can. So that's what anxiety is. It's telling us there's something dangerous around that I need to pay attention to, and I need to do something about this. It tends to be future focused, not if something is going wrong in this moment. It's really if, my brain kind of going to the place of like something could go wrong in the future, and I need to pay attention to that maybe. So that brings us to the interaction between anxiety and our breathing. And anxiety can be triggered by a lot of different things. It can be triggered by the thoughts that we're having. Sometimes it kind of comes what might seem like out of the blue. Our thoughts start to kind of roll, and then we feel anxious because of that. We can also feel anxious because of physical things that we feel. And so if there are changes in our breathing, for a lot of people, that ends up bringing on a feeling of anxiety. We notice that feeling and we say, oh, gee, I'm feeling anxious, or, oh, gee, this isn't good. Okay. So with that feeling of anxiety, whatever it's causing it, we start to feel a bit breathless. There's a change that happens in our breathing because of that anxiety. And that leads us to have some worried thoughts. And it might be, really intense ones like, oh my goodness, I'm going to die, or it might be just, I'm out in public. I don't want people to see me like this, a little bit of worry about, kind of what the impact might be. That can lead us obviously to feel a little bit anxious, panicky, kind of overwhelmed. And in turn, that itself will bring on more physical changes. So it's going to tighten our chest. We're going to start breathing a bit faster. We're not going to be in our best. And that, of course, then keeps that cycle going. I feel even more breathless and I get even more worried thoughts. Then I feel even more anxious, panicky, overwhelmed. And it keeps going until I'm able to interrupt that cycle. And we're going to talk a little bit more in a bit about how to interrupt that cycle. So when I have COPD or some other lung disease that's going on, and I have anxiety, that's going to lead me to feel a few different things. I'm going to feel not so great about myself. I'm going to have a little bit of low self-esteem probably. Apathy in terms of like nothing is really going to feel appealing. Like, am I going to even be able to enjoy it? I used to enjoy going on hikes, and maybe I can't anymore to the degree that I would want to. And so, is it worth it even going on a walk around the block? So that's, the feeling of apathy that we're talking about here. And then, one of the more serious consequences can be, that we are less adherent to the medical advice that's being provided to us by our healthcare providers. That in turn can lead to, some pretty dire consequences in terms of maybe, getting into that red zone, as Tina was talking about in the last talk. In terms of needing to be hospitalized, needing to go to the ER because the symptoms have gotten so out of control. So on the other hand, depression's a little bit different. And what that is really, this constant state of like feeling really low, not really interested in anything. Nothing seems, exciting at all. Or I just feel kind of numb. And it keeps you from doing the things that you would normally enjoy doing. And this is really a very common reaction to any chronic illness. So, if we see people with heart conditions, with cancer, oftentimes depression is something that we're screening for and really kind of keeping an eye on the symptoms of. And this is the reason. So when I do have a chronic illness, I feel quite limited in terms of what I'm able to do, and that's going to lead me to feel depressed. But then, of course, the depression itself has an impact on my ability, on my health and my well-being, and my ability to do things that, would generally be healthy behaviors for me. So it increases the inflammation in my body. It gets in the way of me doing things like sleeping well, eating well, doing, medical care that I would normally be able to do. Our schedules are thrown off. I just don't feel like it. Why am I even bothering? So, all that cycles back and forth. So we have this lovely interaction back and forth between our health and then the depressive symptoms that keep it going. And as you see at the bottom there, and I don't remember my source for that, but it was a reasonable source, I promise you. The depression rates for COPD are somewhere between 10 and 80%, depending on where you're getting your stats from, which is actually quite significant. So what can we do to help with, helping with anxiety and depression? Both, thankfully, have very similar things that we can do to get them, to get those symptoms doing a little bit better, to ease them up a little bit. And that's because they have a common pathway and a common kind of background. So the tools that we're going to review today, some of them may work a tiny bit better for anxiety, but in general, they kind of both have some really positive benefits no matter what you're struggling with. Or if you're struggling with both, then you're kind of doing 2-for-1 treatment, let's say. So the first one is mindfulness. And it's one of the things that I like to talk about a lot because it's such a quick and easy thing that we can throw into our days. So when we talk about mindfulness, what we're really talking about is really just to focus on the present moment. So we don't need to be sitting on a particular cushion or, to have, a certain number of candles lit around us or anything like that. What we want is something quick and easy that we can integrate into our day that's just going to remind our body that, oh, right, I'm not in that future place of having to pay attention to something that might happen. And maybe, I don't have to think about, where I used to be and how that's, in line or not in line with where my body's at right now and where my symptoms are at right now. So really giving myself a little bit of a break in the present moment where it is. And I always say, in general, if I'm able to take that moment, it's because I'm in a safe place. So I don't need to be paying attention to dangers at that time. So the 3 little activities that I usually go through, the first is 5 senses, and it's pretty much exactly what it sounds like. It's really going through each of your senses and paying attention to, what do I hear? What do I see? What do I smell? What do I taste? And what do I feel? So I always joke with my clients, if you can do it in my office, you can do it pretty much anywhere. So right now I'm hearing the air kind of coming into my office. I keep some little bottles of some essential oils around to be able to smell. So, because there's no rules with mindfulness, we don't have to do it a certain way. We can have things on hand that make that task a little bit easier, or are just frankly enjoyable smells, enjoyable things that we like to taste. Maybe a nice warm cup of tea, or a certain food that we enjoy taking a little bite of. The second one is the National Geographic approach, and that one's a little bit of a unique one that I like to share. So what happens is when our minds in particular are in that anxious place where the thoughts are kind of cycling through and through and through, oftentimes they're rolling by really, really quickly. And we end up feeling the impact of them without really, kind of spending time noticing what those exact thoughts are. So what we do is we use the National Geographic approach to slow them right down. So if anybody's watched any of those nature shows with David Attenborough, as he narrates like the cats walking across the savannah, and how they're chasing each other, he does it in a really calm, monotone kind of way. Like you can't, even if it's the most nail-biting moment, somehow you feel absolutely at ease with this moment based on how he's narrating it. So that's what we're doing. We're kind of narrating what's going on internally, but doing it in a really calm way where we're almost interrupting that natural cycle. We're letting our body know that we're paying attention to what's going on inside, to what's going on inside in terms of our thoughts as well, but that we're giving it the input that this isn't dangerous. So I'm noticing that, my heart is beating a little faster. I'm noticing some changes in my breathing, and I'm not sure where that's going to lead to right now, but I'll just spend some time noticing that and keep an eye on that. So really doing some of that self-talk, and you can do it externally or internally, depending on kind of what's most comfortable, and just giving yourself that constant input. And then I added in there a walking meditation. And what I meant by that was really just noticing what it's like to take the steps. And when I say walking meditation, like you don't need to be out in nature. You don't necessarily need to be literally anywhere. You can do it even around, the room that you're in, walk back and forth, and what you're doing is you're just noticing what it feels like to take those steps, what it feels, how your body is responding to each step, maybe how many steps you're taking back and forth. So really adding in a little bit of a component of almost giving my brain something to focus on, that's not all the thoughts that are normally taking up its energy. Then we get to breathing exercises. So if my breathing's, not doing well and I'm feeling anxious about it, is the breathing really going to do anything in particular? And the answer is generally yes, especially if we're not in that red zone. There are things that we can do to, potentially bring that back down to the green zone. One of them is doing some of these breathing exercises, that might just make us a bit more comfortable. And that might slow down some of that, all the other impacts. So one of the ones that's one of my favorites is diaphragmatic breathing. So with diaphragmatic breathing, or belly breathing, as I like to call it too, what we're doing is we're breathing right into our bellies. So we were doing a little bit of that on the activity break, which I was really happy to see. So essentially, as you're breathing in, as you're taking in the air, you're inflating your belly. You want it to kind of rise. And then as you're exhaling, that your belly is kind of falling. Okay. And even, 5 deep breaths, 10 deep breaths, of diaphragmatic breathing, even that can bring down our level of anxiety, can make us feel a little bit more in tune, can, even give us a little bit more energy to some degree. So all of that can be really helpful in terms of just kind of supporting us in the moment. And what it does when we're doing that diaphragmatic breathing, we're kind of using the same pathways that are used for anxiety. It's the same pathways that get used for calming us down. So if we're using them for calming us down, then our brain, almost has this automatic like switch. It's like a train track switch almost, that says, oh, right, okay, we're using it for relaxation, all's good, we don't need to keep that piece on. And so it kind of turns it off. Box breathing is another one that's kind of fun. So this ball is kind of just indicating how you would go about doing that. It's probably a little quicker than I would normally do it. Usually it's about 4 or 5 seconds. I did try to change the timing, but my technology skills are not that advanced. So what we're doing is we're inhaling, we're holding the breath, we're exhaling, and we're holding the breath. And each of those for about 4 or 5 seconds. or whatever you can manage, so that we're kind of getting that box style breathing. And then pursed lip breathing, which actually can be quite helpful as well. So where we're kind of breathing in and then breathing out through our pursed lips. Aside from breathing, other things that we can take use to kind of exert some control and some well-being over ourselves. Sleep is a big one that I tend to focus on a lot with people, especially, frankly, with anxiety and depression, but especially with my folks with depression. Sleep tends to be the first thing that kind of falls off the rails, and it can be really hard or feel really challenging to kind of get it back on track. So there's a few key things that we can do to kind of get sleep back on track. The first is sleep hygiene. So those are things like making sure that the room is dark enough, that I'm in a comfortable sleep position, the temperature of my room is okay, that I haven't had caffeine like, a couple hours before bed. All of those things really just kind of support our sleep and our attempts to get to sleep a little bit sooner, and on schedule, let's say. The second piece of paying attention to our sleep is what I like to call stimulus control. So especially if we're feeling not so great, a lot of times we're looking for that comfort, we're looking for a cozy place. Our tendency might be to stay in bed for longer periods of time. And while that feels really, really good in the moment, it can get in the way a little bit. So what that does is it tells our brain that we like to be both awake and asleep in bed. And really what we want our brain to focus on is that when we're in bed, we're in bed because we're going to sleep. So the more time that we spend awake in bed, the harder it is to fall asleep. And then we might need to do, a little bit more work on that. So one of the big recommendations that I can make, if you're feeling depressed, is really just to spend some of that time elsewhere. So, it can be the couch with a comfy blanket and all the pillows in the world. I'm so for that. That sounds lovely. And that would be great. If you're low on space, if you live in an apartment where there's not a whole lot of room to be able to do that, then even just being in a slightly different position, or on the opposite side of the bed, or something where it's just going to give your brain that idea that, okay, this is not exactly the same as when I'm going to sleep. The third one is probably, a really important one. And it's probably something that unfortunately you've heard throughout the day, but the importance of following treatment recommendations. So if I'm not doing the things that allow me to breathe well, certainly that's going to get in the way of being able to sleep well and to stay asleep. So if I'm following those treatment recommendations, if I'm taking, the puffers, inhalers, whatever it is that I need to do before I go to sleep, that's certainly going to help me to be able to stay asleep, to fall asleep a little bit easier, and just to get a more restful night's sleep overall. Eating well, that one's a really important one. So having, a proper diet when we're not feeling great. I don't know about you, but my brain immediately goes to all the chocolate in the world. And although I am such a fan of chocolate, everything in moderation is what I am told. So I will leave it to the professionals to tell you more about, eating and how that's helpful. But certainly having a balanced diet is really important in terms of taking care of our well-being, both physically and psychologically. Progressive muscle relaxation is another fun one that I really enjoy because, it makes such a big difference and it can do it in such a little amount of time. It also can be a nice, useful tool for helping us to fall asleep at night if used properly. So with progressive muscle relaxation, what we're doing is we're going head to toe, one muscle group at a time, and we're tensing up that muscle for just a short amount of time, 5 to 10 seconds, and then letting it go. And what that does is it kind of overexerts the muscle and it forces it to relax so that we don't have a choice but to relax that muscle. And once our muscles are relaxed, that certainly makes it a little bit easier to fall asleep. Uh, Tension is kind of the opposite of what we want when we're looking to fall asleep. So with progressive muscle relaxation, you might need to do it a couple times. You might need to revisit some muscle groups where tension tends to, stick around a little bit longer. That's okay. It's sometimes hard not to get frustrated with that. But really what you're doing is you're just trying to do your best. You're just training your body to be able to go to that state a little bit quicker than the last time you did this. And then exercise. So I love that we took a little activity break. And I will be honest, I did the exercises along with Tina because I have been sitting all day and working. It's nearing the end of my day over here. So I needed a little stretch break, let's say. So with exercise, what we're looking to do is, we're not going to jump in and suddenly decide we're going to run a 5K or anything like that. We're setting realistic goals. Maybe it's that, I go to my mailbox and back up, and that's it for the day. And that's okay, because what we want to do is the second piece, right, is to start slowly and then increase gradually. And what that allows your body to do is both acclimate, but also it gives you a chance to see, okay, where is, my tolerance window? And what does my body respond well to? And what does it suddenly respond to not well to? So it gives you a bit more control over how your body's feeling and what things feel like for you. Plus, I'm all about living for successes. So if I start small, then I know I'm going to be able to succeed at it, versus jumping right in, again, with my lovely 5K that I wish I could run, I know I'm not going to be able to do that, but I know I can walk, for 5-10 minutes and come back and feel well. So I'm going to do that. And then the third piece is you can add in some mindfulness. So, I like 2-for-1s. This is the most awesome 2-for-1 special here. So as I'm doing some exercise, I can build in some of that mindfulness that we talked about at first. So maybe I use my 5 senses, and notice some of the smells and tastes and, how my clothes are feeling on me as I'm taking that walk. And notice some of the thoughts that are coming into my mind and really slow them down and do some of the National Geographic work with that. And then I think one of the most key pieces is spending time with others. So with anxiety, with depression, our world, and certainly with chronic illness on its own too, the world becomes a lot smaller feeling. So connecting with people, whether it's through platforms like this, through, calling up a friend or, joining a group online, for example, each of those things, that connection with others is so incredibly important to our mental health and really does help a lot with feeling anxious and feeling depressed. So that's probably one of the key things that I'll leave you with. And then, I'm definitely open to any questions that anybody might have for me. I love answering questions.
Thank you so much, Sarah. As you were speaking, I had posted in the chat if anyone uses any mindfulness techniques already, if there's anything they found worked for them. So one of our participants said yoga and meditation, and I invite anyone else that has used any of the treatment options Sarah's put forth, anything that's worked for you, please let us know in the chat. Sarah, thank you so much for that wonderful talk. I think like listening through, especially with that anxiety, breathlessness cycle, we hear from our participants that they feel that. And I think just any of us humans, I feel at times we certainly can be prone to being in that cycle. So once we've identified that, maybe we put, okay, the label, okay, this is anxiety or I'm feeling anxious. You've offered us some tools, some mindfulness tools, for example. But do you have a recommendation on which one to pick? Like, which one do we focus on first? If we were just gonna kind of lay it out for ourselves, what step one, step two, step three might look like. Any suggestions?
I love that question. Yes.
Yeah.
So, and maybe my answer will be unsatisfying, but I'll give it anyways. You know, it's so important to have a menu of options available because on different days, when we're listening to our body, when we're checking in with ourselves, am I green? Am I yellow? If I'm red, I'm probably not doing well, but if I'm green or yellow, and what am I noticing in my body, that's going to give us some cues as to what my body is asking for today and what feels reasonable today. So I think the best answer to that is, focus on something small, something that feels manageable. And that's going to be something different for each person, which is why I'm saying my answer might not be satisfying, So, if sleep feels like a really overwhelming thing, like I only sleep, 3 hours a night, and that just seems like a lot of work to get to a place where my sleep is more, put together, then maybe I start with something like just integrating the five senses, But if that's going to be something really big for another person, then maybe I'm just working on, I don't know, not drinking caffeine after, 3 o'clock so that, I have a good night, as best a night's sleep as I can have. Or I work on, just taking, a 2-minute walk, for example, to the mailbox and back. So just working with your body. So I would say kind of pick the top three things that really kind of spark, a little bit of, either like, oh, that sounds actually interesting or enjoyable potentially, or, that's something I'd really like to work on, and have those as kind of your go-tos. And then you can always add in more later, as things get easier feeling, then, you always have the opportunity to add in other strategies, and other, goals that you're kind of working on and towards.
Awesome. Yeah, it sounds like a lot of advice that we give too, especially with the action plan, for example. You practice certain things regularly when you're feeling well. So it's kind of second nature, or you know what to do in that moment. And then when things start to change and maybe you're a bit more frazzled on what your next step it's easy to go to that thing that you've kind of been practicing or doing.
You bet.
Yeah. Amazing. We did have a question that about COPD exacerbations specifically, and the question was, do people living with COPD get anxiety as a result of having an exacerbation? And in that particular circumstance, what strategies might be helpful? And I think you've touched on this a little bit, but just if you have any more you wanted to say about it.
Yeah, so absolutely, a lot of what I see with a lot of different chronic health conditions, definitely COPD, when there's an exacerbation of symptoms, when, things get worse, whether it's, for a little bit of time or for a prolonged period of time, it's a natural place for our brains to go to really start to worry about that and to feel, really anxious about that. It's not easy to see those changes in our bodies, again, whether they're short-lived or whether they're long-lived, because our brains naturally go to places of like, is this going to be, every month, how often am I going to feel that? How long am I going to be at this level of, feeling okay? When's the next time that my breathing is going to, have an exacerbation? All of those things are naturally going to come to mind. So yeah, so with those moments, one thing that you can remind yourself is, of what you're dealing with in the here and now. So bringing it right back to that present moment. Yes, that was really scary. That was uncomfortable. I didn't like that, but right now I'm okay. I'm, hopefully at the point that you're doing this back to, some version of stable, and then, knowing that, what I have to look for the next time. So I have my action plan at the ready. My healthcare providers know what works best, and I know the strategies that tend to keep me in a good, stable place, generally speaking, on most days, because again, that's kind of the fun with chronic health conditions in general, right? Is that sometimes they unexpectedly go awry. So just reminding ourselves of, kind of almost talking back to some of those anxious thoughts that are naturally going to be there, and knowing that that's kind of a natural place for our brains to go when something really scary has happened, because our brain is really trying to protect us in those moments.
Yeah. And that self-talk, I loved your last point there, which is just striving to have people around us. And because you're absolutely right, living with this lung condition can be very isolating. And so using our own ability, our own strength to self-talk ourselves into still connecting with people is so important. And as we close things off, I just want to bring some focus to your mantra here, which I think is just lovely. So every breath is a reminder of your strength. Even when COPD makes it challenging, your resilience shines through with each inhale and exhale. So thank you so much, everyone. Thank you, Sarah, for being here. To all of our speakers, to our participants, we wish we could see you, but thank you so much. This forum has been recorded and will be uploaded to the BC Lung website. That was a question that we had. And we're getting lots of thank yous in the chat box, Dr. Sarah. So thank you so, so much. And we bid you adieu and wish you all a fantastic rest of your day.
Thank you, everyone. Check back at bclung.ca for more information, or check out the Poplar community at poplarpulmonary.com if you're looking for any follow-ups, or if you wanted to ask some of your questions that unfortunately didn't all get answered today. There's so many. So please do reach out. It was great to have so many people attending here today. Thank you so much, Sarah.
My pleasure. Thanks so much.
Yeah, thank you. Good to see you again.